Hello friends. So today in this video, I'll be talking about cholelithiasis or the gallstone disease. Now, as you all know, that gallstone disease is a very common problem in our country, especially in the North India. And I think in any of the surgical practices, cholecystectomies are probably the most commonly performed surgeries, and the most common indication is cholelithiasis. So, it is a very important topic both for your professional examination as well as for your PG entrance examinations. So, first of all, we'll talk about the types of gallstones. Now, the gallstones are divided into three types. These are cholesterol stones, mixed stones, or pigment stones. Now, I would like to emphasize on one point here, that is, all of these kinds of stones consist of cholesterol. It is only the percentage of cholesterol that differs in any of these kind of stones. So, all stones have cholesterol, but the percentage of cholesterol varies among the different types of stones. Now coming on to the cholesterol or the pure cholesterol stones. Now the pure cholesterol stones are actually rare. Rare means they happen in only less than 10% of population, and they consist of approximately 99 to 100% of cholesterol. Now, as you can see in the figure over here, that these stones are usually solitary. They have a smooth surface. Okay. Now coming on to another variety of stone, that is the mixed stone. Now these mixed stones are actually the most commonly found variety of gallstones throughout the world. Second, the amount of cholesterol in these kind of stones is approximately 51 to 99%, and the other component being calcium salts. Now, as you can see in the picture over here, that these stones are usually irregular in shape. They are multifaceted. Okay, and they may be hard depending on the amount of calcium salts in these stones. Now coming on to another variety of stone, that is your pigment stones. So these pigment stones are actually different from these cholesterol and mixed type of stones. Of course, they do have cholesterol in them. The amount of cholesterol in the pigment stones is usually less than 30%. And these pigment stones are further subdivided into two types, that is the black and the brown pigment stones. The black pigment stones consist of calcium bilirubinate, and as you all know that bilirubin is a product which gets produced because of degradation of hemoglobin. So it is obviously seen in patients who have hemolysis, which is there are several hemolytic anemias, and these patients of hemolytic anemias, they present with black pigment stones. For example, sickle cell disease, thalassemia. Okay. Now, apart from the patients who already have this disease, these black pigment stones are also found in patients with cirrhosis and the patients who are of old age. Now you can see in the picture over here again that these are usually small black colored stones which are brittle in nature. Okay. Now coming to our final last variety, that is the brown pigment stones. Now all of the previously discussed stones, that is the cholesterol stones or the mixed stones or black stones, these stones are usually formed inside the gallbladder. But on the contrary, these brown stones are formed inside the CBD, and they occur in patients who have certain predisposing problems. For example, there is stasis of bile in CBD, which may be due to pre-existing CBD stones, or there may be parasitic infestation of the CBD, or there may be cholangitis or infection of the CBD. Okay, so all these, or even they may also be found in patients who have a pre-existing stent inside the CBD. So all these conditions, they predispose to formation of brown pigment stones, and these are usually soft and mushy in nature, and they happen. Why are they formed? They are formed because of action of some enzymes which are produced by the bacteria, and though that enzymatic action over the bilirubin leads to formation of brown pigment stones. Now another very important topic for both of your exams is how and why does gallstones form. So in the last slide we have talked about several varieties of gallstones, and we have briefly discussed about the pigment stone formation. Now we will discuss about how does mixed and cholesterol stones formed. So as we have already discussed in our last class, that bile consists of water, electrolytes, bile salts, cholesterol, bile pigments, and phospholipids. Okay. And one of the most important function of gallbladder is absorption and concentration of bile. So what happens in GB? In GB there is concentration of bile to up to 10 times. Okay. So once this concentration happens by absorption of water and electrolytes. So once water and electrolytes gets absorbed, it leads to very high concentration of all other elements that are present in the bile, that is your cholesterol or bile acids or bile salts, etc. Okay. So we have this bile that is present in gallbladder is actually a concentrated bile which has high amounts of cholesterol and bile acids and bile salts and lipids, etc. Now another important thing here to note is that cholesterol is actually a non-polar compound. Non-polar means that it is insoluble in water. So cholesterol is not soluble inside water. So how does cholesterol gets transported in bile? So cholesterol, it gets associated with phospholipids or bile salts in the form of vesicles and micelles. So we can assume that this is a vesicle or a micelle where we have cholesterol plus phospholipid plus bile salts. Okay. So this is how cholesterol gets transported inside the bile. Now how and why does gallstones form? So one prime requirement for gallstone formation is supersaturation. Okay. supersaturation of bile with cholesterol. So now I'll be talking about we have discussed already that how does stones form. So the first and foremost thing that is required for stone formation is supersaturation of cholesterol in bile. And now we will briefly talk about what all factors that are present that may lead to this kind of situation. So this supersaturation of cholesterol inside bile will lead to formation of stones, and this may happen in patients who have increased age, who are obese. Okay, there is high content of fat in diet. Okay, certain drugs, for example OCPs. Okay, so this is one of the reasons why gallstones form. Now, as we have already talked that there are micelles and there are vesicles where cholesterol stays in harmony or in homeostatic or stable state with phospholipids and bile salts. Okay. So, one thing is that there is high amounts of cholesterol which may lead to formation of stones. Another thing is that there is decrease in bile salts. So if there is decrease in bile salts, there will be a relative rise in concentration of cholesterol, which will lead to crystallization of cholesterol stones and hence formation of stones. So another thing is that there is decreased bile salt. So what all reasons can be there which leads to decrease in bile salts? So I hope you all remember about our last class where we have discussed about enterohepatic circulation. So approximately 95% of bile salts gets reabsorbed from the terminal ileum and they via the portal vein come back to the liver. Okay. So if somehow there is a derangement in this enterohepatic circulation, there will be higher turnover of bile salts and hence there will be a lower concentration of bile salts in the bile. So what all conditions can lead to poor enterohepatic circulation or decreased bile salt concentration in bile? So first is resection of ileum. If suppose there is surgery done on the patient and patient has undergone resection of ileum due to any reason, so these patients are at an increased risk for formation of gallstones. Second is inflammatory bowel disease. Inflammatory bowel diseases, we will discuss about it when we are discussing in the chapter of colon. So inflammatory bowel disease will lead to a poor absorption of nutrients and of course bile salts. So this will lead to a decrease in concentration of bile salts. And ingestion of cholestyramine. So cholestyramine is a drug. It is a bile acid sequestrant, bile salt sequestrant, and it is used for treatment of hypercholesterolemia. So patients who are taking cholestyramine, they will be at an increased risk for formation of gallstones. Now there is another factor which is dysfunction of gallbladder. So gallbladder, it tends to contract in response to food. So once the person takes food, there is secretion of certain hormones which leads to contraction of the gallbladder and thereby secretion of bile into the CBD and hence into the intestine. Okay. So if in any case the gallbladder is not able to contract properly, so there will be again increased concentration of bile inside the gallbladder, which will lead to stone formation. So GB dysmotility will predispose to formation of stones. Another thing is, if suppose there is a patient who is on prolonged total parenteral nutrition. So if suppose the patient is not eating anything and patient is being on total parenteral nutrition, in that case again gallbladder will not contract and there will be increased concentration of bile inside the gallbladder which will lead to stone formation. Prolonged starvation also will lead to formation of gallstones because of the similar reason. Now another important factor is there are certain pro-nucleating agents. There are certain agents which tends to increase the formation of crystals of cholesterol, and these are uh, mucus that is secreted from the alveolar glands in the neck of the gallbladder, or there is infection. So I hope this is clear that how does gallstones form. So majorly you all have to remember just few points. First is supersaturation of cholesterol. Second is decrease in bile salts, which again may be because of resection of ileum or inflammatory bowel disease or ingestion of cholestyramine. Then dysfunction of gallbladder or GB dysmotility will also lead to formation of stones. Now coming on to cholelithiasis, its natural history. So it has been found that majority of the patients have an incidental finding. That is, they get an ultrasound done for some other reason or as a routine checkup, and they get to find that they have gallstones. So first thing, that majority of the patients, they have gallstones, but it is found as an incidental finding. Now another important point over here is that only 20 to 30% of patients who have gallstones will develop symptoms over a period of 20 years. So that means only 20 to 30 out of 100 patients of gallstones will develop symptoms over a period of 20 years. And another important point is that only 1%, that is 1 in 100, will develop complication of gallstones, without having any prior symptom. So a big question here is whether to operate each and every patient of gallstones. And this question has been asked in several examinations, and this will be asked in your professional examinations as well. That do we need to operate each and every patient of gallstones? The answer is no. Okay, why? Because only 20 to 30% of patients will develop symptom over their lifetime. Okay, and only 1% will develop any complication without any previous symptoms of gallstones. So that is why there is no need to operate each and every gallstone patients that you come across. First thing. Second thing, here we will talk that there are certain indications where we need to prophylactic cholecystectomy, and these are: first is in patients with hemolytic anemia, that is the patients who have say sickle cell anemia. As these patients have black pigment stones, that is okay, but once if cholecystitis occurs in these patients, there will be crisis. Okay, so it will be difficult to manage that crisis. So that is why it is recommended that every patient who has any hemolytic condition, they should undergo a prophylactic cholecystectomy. Large stone, that is large stone which is more than 2.5 centimeter, these patients will require surgery because there is increased risk of development of malignancy in these patients. Then porcelain gallbladder, again this is a increased risk of malignancy, and that is why it is better to get the gallbladder removed prophylactically. Now there are certain doubtful or certain indications where it is not clear whether to operate or not, and it usually depends on the surgeon's preference. So diabetic patient, as there will be difficult to manage if any complication of cholelithiasis occurs. Along with bariatric surgery, why? Because weight loss leads to formation of gallstones, and so these patients are prone to develop cholelithiasis. But this is again, this is not being followed worldwide, and again it depends on the preference of the surgeon. Then along with transplant surgery, why? Because there will be immunosuppression in these patients that will be required. So again, to prevent any undue infection or say cholecystitis or anything which will be again difficult to manage in these patients, so it is recommended. It is again doubtful. It is said that it may be or may not be done. Again, it depends on the preference of the surgeons. So now coming on to symptomatic gallstone disease. So what are the clinical features of symptomatic gallstone disease? So first is pain, which will occur in the right hypochondrium or epigastric region. There may be nausea and vomiting in these patients. There may be bloating. And the characteristic of pain is that it is usually colicky in nature. And what is a colicky pain? So colicky pain is the pain which happens, which is sudden in onset, which is severe in intensity. It may last from few minutes to up to a day, that is 24 hours, and it usually gets relieved on its own. Okay, so these are a few features of colicky pain which you need to remember. And the thing is, how does gallstones cause pain? Is that, say, this is your liver, this is your gallbladder, and there are multiple stones over here. Okay, so once the patient eats food, the gallbladder contracts in response to cholecystokinin and secretin, and once it contracts, there is a gallstone which gets obstructed at the neck of the gallbladder. So this will lead to colicky pain. Okay, why? Because gallbladder is trying to contract against an obstruction. So this will lead to pain. Now, how to diagnose? So ultrasonography, a USG of the abdomen, is actually the investigation of choice and first line of investigation for cholelithiasis. First thing. Secondly, it is more than 90% sensitive and specific for gallstones. And how does a gallstone, how do we see the gallstone on ultrasonography? So we can, with the help of this picture over here, see, this is the stone here. This here is the stone. So this stone, gallstones are radiodense. So there will be a stone which have a posterior acoustic shadow. You can see here, this is posterior acoustic shadow. So this is how we diagnose gallstones on ultrasonography. Now, now suppose if we are planning for a surgery in a patient who have symptomatic gallstone disease, what all other information do we get on ultrasound which is also important for our clinical and surgical management? So we have to see first presence or absence of gallstones. Second, size and number. Number means whether there is a single gallstone or there are multiple gallstones. Okay. Size and number of gallstones. Thirdly, wall of gallbladder, whether there is any thickening of the gallbladder. What will the thickening indicate? Thickening will indicate that there has been either acute episode of cholecystitis or there is a chronic cholecystitis that is present. Then size of the gallbladder. Size, why is size important? So what happens is that in a patient who has got gallstones for a long duration of time and there are multiple attacks of biliary colics. So in these patients there will be scarring and fibrosis of the gallbladder, which will lead to chronic cholecystitis, and the gallbladder will usually be contracted. And these kind of gallbladders are usually difficult to operate because the anatomy is not very clear, and the Calot's triangle is usually frozen. Then we have to see the diameter of the CBD, whether there is any dilatation of CBD or not, whether there is any stone or calculi in CBD, or there is any extrahepatic or intrahepatic biliary radical dilatation. Okay. So these are all the information that we tend to get in a ultrasonography, and this is all important because if there is anything which we have discussed, it will change the line of management. Suppose there is a CBD calculi, you are not going to operate that patient. That patient will first require a ERCP. Well, we will be discussing about all these complications again. All the complications, for example, acute cholecystitis or empyema of gallbladder or Mirzi syndrome or chronic cholecystitis. I'll be discussing all those complications in a separate session. But as of now, you all should know that how does a gallstone look like on ultrasonography, how to diagnose a gallstone disease, and what all information you have to gather and we can gather on a ultrasonography. Now, lastly, treatment. So, undoubtedly, treatment for symptomatic gallstone disease is laparoscopic cholecystectomy. And why I am emphasizing on laparoscopic word over here is that it is actually gold standard technique worldwide. Previously, it was used to be open cholecystectomy, but since now we have enough of experience and our systems of laparoscopic systems have improved a lot. So, laparoscopic approach for cholecystectomy is now considered the gold standard line of management. And I'll be discussing about laparoscopic cholecystectomy in a separate session where we will talk about everything about laparoscopy and cholecystectomies. So as of now, friends, this is all for this session. I hope I hope it is clear to you all that how and why does gallstones form, how does a patient with a cholelithiasis present to your OPD, and how to diagnose it. So thank you.